on to Dr. Satish.
The next talk is by Dr. Satish Kulkarni on the silent killer hypothermia. He is presently the consultant anesthetist at Leelavati Hospital, Mumbai.
Good afternoon. Thank you, Bala. I'm going to talk about hypothermia, the silent killer. So basically what I'm going to do is going to talk about what does hypothermia mean, what sort of consequences it can have in the perioperative period, especially what we are interested in. And if the time permits, I'm going to talk a little bit about prevention and issues which have come up recently. So let's get on with the talk. And what I mean is I'm going to talk about mild perioperative hypothermia. Now, what do you mean by mild perioperative? One, when we talk about hypothermia, I'm not going to talk about surface hypothermia or peripheral temperature. It's going to be about core temperature. And when I mean by the core temperature means is the temperature of the deep tissues of the body, which is extremely necessary for the optimal function of the tissue enzymes, which are extremely sensitive to temperature changes. Human beings as well as some birds and mammals are homeothermic, which means that any change in the core temperature would initiate behavioral and physiological changes which will get back the temperature to the near normal range. And what is the normal range of the core temperature? Is about 36.5 to 37.5. Now there are a lot of issues about this, what exactly is core temperature, because this so-called data has been originated 140 in 1800 from a single worker, Karl Wunderlich from Germany, that what he mentioned, this has been debated whether actually, because each patient, the moment I give propofol, atracurium, and whenever we are going to intubate, first thing it goes is that a rice tube goes in, the temperature probe goes in the distal esophagus, and then the endotracheal tube. And next minute, the way I look at the end-tidal carbon dioxide, I look at the temperature. And most of the times you will be surprised to find 35.8, 35.6. I've seen up to 35.5 as a first temperature within 1 minute of induction. So that is one. I'm not going to talk about long cases like cardiac cases, pediatric cases, which probably all of them do monitor temperature. What I want to talk about are short cases about an hour duration, where it is going to be very important because the way the pattern of hypothermia in the perioperative period, in first 15 minutes to half an hour, there is a massive drop of temperature by 1 to 2 degrees centigrade in the core because of the various reasons, and it does take a long time to come up. So by the time you are at the time of reversal, your core temperature is much lower, which has got a lot of complications and consequences. So let's look at now perioperative cardiac events is the major unanticipated morbidity and mortality in the perioperative period. It has got high mortality as well. This data by Frank and SM in JAMA 1990, it says that perioperative hypothermia tripled the incidence of adverse myocardial events in high-risk patients. There was a randomized control trial, 300 patients, coronary artery disease patients coming for major non-cardiac surgery, and what they noted was there was over 3 times increased incidence of arrhythmias, ventricular tachycardias, ventricular arrhythmias, myocardial ischemia, and infarctions. Another study which was in 2003 said intraoperative normotherapy attenuates myocardial injury during bypass as reflected by reduced levels cardiac troponin. And there are various other studies done in gynae, orthopedic, vascular, cardiac, and all these things, which is probably all of them have higher incidence as well. Now, what could be the mechanism? When I trained, I was always told that in a high risk individual, if there is hypothermia, they will probably shiver, and that would increase sympathetic stimulation, there would be hypertension, tachycardia, increased oxygen consumption, increased respiratory rate, and in a patient who is high risk may not be able to compensate for the increase in the oxygen demand, and probably they would ischemic and have myocardial ischemia and infarction in the perioperative period. However, that doesn't seem to be true because high risk patients and elderly patients rarely shiver. Elderly patients will have diminished your thermoregulatory controls, so they rarely shiver. Intraoperative, normally most of the opiates will reduce the shivering, hypoxemia reduces the shivering or suppresses shivering, and oxygen consumption, which I was told has increased by 400%. It is never true. In extreme conditions in young fit athletes, it never goes above 200% at best. So in the perioperative period, the likelihood of oxygen consumption going so high to actually cause ischemia seems to be unlikely. So shivering doesn't seem to be the main cause. What it could probably is a cold-induced hypertension. It has been shown that if cold-induced sympathetic stimulation hypertension, especially in the elderly and high-risk patients, the noradrenaline levels are almost 3 times higher than normothermic patients. Adrenaline levels doesn't seem to be that high, and this increase in the noradrenaline levels probably give rise to hypertension, cardiac irritability, arrhythmias, and causes probably increase in the. So this hypothermia per se is independent factor causing increased incidence of perioperative cardiac morbidity. Second, coagulability. There is a lot of data basically show that if the patients are hypothermic, there is increased incidence of bleeding. This mild analysis, these are all randomized controlled trials. Mild intraoperative hypothermia increases blood loss in allogenic requiring total hepatoplasty. Their estimate of the 2-unit transfusions were higher in by just 1 degree decrease in the core temperature. The core temperature going to 35 degrees, there was higher incidence of blood transfusions in those patients. The same data was repeated by aggressive warming and reducing blood loss during hip arthroplasty. They also noted that blood loss was more and probably the chance of infusion or transfusion requirements is much higher. There were a lot of studies done in various other surgeries as well. There were orthopedics, gynae, vascular surgery. So Raj Gopalan in about 2008, they had a meta-analysis about the effect of about mild hypothermia and blood loss, and what they noted was the blood loss was overall in most of the studies increased by about 16 to 20%, and the relative risk of a transfusion requirement is about 22%. Now, in recent data about blood transfusions and increased risk, apart from the known risk of infections and everything, there is huge data about immunodepression which causes blood transfusion and probably of cancer recurrence, XYZ. So that is what it is more concerned. It is a significant that if you can avoid allogenic transfusions, that would be safer. In reducing blood loss following spine surgery, but however this group did not find much difference. However, the patient data was very small, the numbers were very small. There were only 70 patients that looked of various factors towards spine surgery which would probably reduce blood loss, and normothermia did not come as a major cause. They do not know why in those spine patients only normothermia, whether it was a technique or whether that specially 70 patient group was an issue. And in the recent this February anesthesiology, this Feb 2015, they looked at intraoperative warming devices and the effect of blood transfusions, and they noted that increased incidence of transfusions required, which is significant. Hospitalization does increase following these, but hospital duration, but the increase in the transfusions was significant. Why this would occur? Probably because platelet count. These are the various factors probably of hypothermia on these issues, platelets. Now we look at the counts do remain normal. However, there are morphological changes in the platelets which increase the aggregation of platelets, which is in contrast to our thinking that the platelet function will be depressed. In vitro, if you see, there is increased binding of the platelets. So probably the cause is not the intrinsic problem with the platelets or the platelet function, but they have been shown that availability of platelet activators does reduce, and there is a release of heparin-like anticoagulant substance with the mild 1 degree decrease in the temperature. That if you look at the clotting factors, the PT-PTT seems to be normal if you do the test. However, all these tests are done at 37 degrees centigrade. So if you do the same test at actual core temperature of the patients, probably you will find a difference. And all the enzyme systems in the coagulation cascade are extremely sensitive to temperature, and there will be prolongation of prothrombin time as well as PTT. Fibrinolytic activity, which has got a good balance between clot formation and lysis. The clot formation, like the plasminogen enzyme, is extremely sensitive, and it could have effect on the fibrinolytic activity as well. However, the studies have not shown a great importance as of the fibrinocysteine in cause of wound healing and infection. Is the major complications of any major surgery. It has got implications as far as the cost, hospitalization and discomfort of the patients. In colonic surgery, perioperative normothermia, it did reduce the incidence of or increase the incidence of surgical site infection in colon surgery patients by almost 3 times. Normal reported incidence about 6%. In patients who are hypothermic intraoperatively, the incidence was almost about 20%. And the increase in the hospital stay was more than a week. Obviously, it has got a lot of cost implications if the patient is going to stay in the hospital for 1 week, apart from morbidity, mortality as well. And similar sort of these things, by pre-warning, they did manage to show that does reduce the incidence of infections. Hypothermia does decrease the wound healing as well as the various mechanism. Probably the scar formation, the collagen mobilization, everything is reduced, and the wound healings. Both these things will have implications as far as the hospital stay cost and your ICU stay and the cost as well. Why this occurs? Probably because hypothermia causes subcutaneous vasoconstriction, there is hypoperfusion, decreased subcutaneous tissue oxygenation and neutrophil migration. all those things, including suppression of the immune response. So all these things which have been factors in the first 4 hours following surgery, what your infection sets in, and that is the reason in this paper about anesthesia roles in prevent surgical site infections, they have highlighted the role of normothermia in the immediate post-operative period and as well as about the antibiotic prophylaxis in the perioperative period. Apart from that, it's very obvious that delays post-anesthesia recovery. Most of our induction agents, inhalation agents are induction agents are metabolized by the enzyme systems in the liver. If as far as the induction agents goes, your propofol concentrations are much higher in the blood in normothermic patients. When you use total intravenous anesthesia, fentanyl infusions at steady state infusions are higher. Inhalations are much more soluble at lower temperatures. The way I look at it is, if you like the Coke or a Pepsi, if you eat in the fridge, you don't get the fizz. The moment it is an outside, you open the bottle and all the gas comes out is something. So all these agents are highly soluble in blood at lower temperatures, which does cause delayed in the recovery. Muscle relaxants, atropurium also the duration is increased. However, vecuronium and rocuroniums are much higher, almost double the time by 1 or 2 degrees decrease in the core temperature. Atracurium increases barely by 50%. And obviously the reversal agents, those also this thing. You can really see that when the temperature is 37 at core temperature, the recoveries are so clear-headed recoveries that you just need to appreciate the quality of recoveries when they are normothermic. And obviously delayed recovery of this thing will have implications as far as your recovery stay as well. This is very obvious. Hypothermia increases the thermal discomfort. You see a patient who is shivering in the recovery room, and you realize that apart from the physiological, that type of tachycardia, hypertension, and XYZ, and the discomfort, it interferes in your monitoring as well. Your pulse oximeter, your NIB, nothing works if the patient is shivering rigorously. And if you look at the satisfaction surveys and you look at these things, what patients rate identify feeling cold in the immediate post-operative, the worst part of the hospitalization, sometimes rating worse than surgical pain as well. And given all the efforts to reduce the surgical pain in the post-operative periods, I think you should go all out to basically make sure the patients are normothermic and they are comfortable. So, because of these complications, various authorities and bodies have prompted recommendations for monitoring and warming strategies to maintain intra and post-operative temperature of at least 36 degrees centigrade this is what I am telling, cold temperature. So that's the reason most of the machines do have temperature. Still I see most of my colleagues and a lot of people do not monitor temperature intraoperatively, and if you monitor, that is the only way you will be able to document the problem and look at how you could treat it and improve it. Thank you very much.